Andrea at the Center for Hip and Knee Replacement at St. John's, and let's take some time to go over one of the most challenging complications of hip replacement, infection. And we're going to talk about how we treat a known infection in the hip replacement. This is something that's just a broad overview. The specifics you should talk with your treating surgeon, but we're just going to go over a basic plan so that you have a roadmap and the vocabulary to have a more informed discussion with your treating physician. Before we get more deeply into this, there are two important things. One is that infection is quite rare, but because it's such a devastating complication, it's still important to understand and be aware of. The second thing is that infection is a very challenging problem for several reasons. One is it's very difficult to make a diagnosis. Number two, there are many different types of treatment plans. And number three, the actual stages of treatment involving exchange are actually complex. For the purposes of this discussion, we're going to focus on how we treat or the specifics of treatment once the diagnosis has already been made and the treatment plan has already been decided. Before we get into the specific roadmap of a two-stage exchange, we'll talk about how we make a diagnosis. And again, making a diagnosis is an inexact science, and it's based on a number of criteria. There are several criteria out there, but most orthopedic surgeons use the Musculoskeletal Infection Society criteria, MSIS criteria. And they look for either definite or indirect evidence of infection, whether it's a sinus tract, a positive culture, an elevated sed rate, an elevated white blood count, or an elevated CRP. There are different ways to make this diagnosis. Okay. For the sake of this talk, we'll assume that a diagnosis of infection has already been made. The next major discussion is how the infection will be treated, whether it's with a two-stage exchange or a one-stage exchange or retention of components with suppression antibiotics or debridement, antibiotics, and implant retention. And so that is the discussion of another talk. But for the sake of this talk, we will imagine that a treatment plan of two-stage exchange has been accepted. So a diagnosis of infection has been made, and the path of two-stage exchange has been chosen. And so I'll walk you through what that path looks like. It is the most common path for the management of Staph aureus and chronic infection. The most common situation for an infected total hip that's undergoing a two-stage exchange is a chronic infection. So it's not an acute infection lasting only a few days. This infection or the pain associated with infection has been going on for weeks to months. It's a long time since surgery. The wound can be purulent, or there can even be a draining sinus tract, and the organism that has been isolated is typically staph. And the reason why implant retention or chronic suppression and keeping your implants doesn't work is two. The first reason is staph has an unusual characteristic in that it can form a biofilm. It's called a glycocalyx. So when it gets together, it creates on top of itself a protective coating through which antibiotics cannot penetrate. So it becomes very resistant to antibiotics. The second thing is that the hip replacement is made of titanium, and titanium does not have, of course, a blood supply. A blood supply is necessary to bring white blood cells and antibiotics to the area of the bacteria. But because the metal lacks that vasculature or blood supply, it cannot by itself fight an infection. So that is the reason. If there is Staph aureus, because of this glycocalyx and because of the inorganic nature of the implant has to be removed. Once it's been decided that a patient is a candidate for a two-stage exchange, there is some pre-surgical preparation. And it's basically obtaining blood samples and a sample of the hip fluid. We like to get blood samples, specifically a sed rate, a CRP, C-reactive protein, and a CBC, so that we can establish a baseline. We expect these values to be high in the setting of an infection, but we expect to follow these values and for them to decrease as the infection is cleared. This will be a good indication that treatment is working, and then once they've normalized, that the patient is a candidate for reimplantation. We also like to obtain a sample of the bacteria, so we will aspirate the hip and then grow it in culture, ideally so that we can have an understanding of what bacteria we are treating so that we can put in the appropriate antibiotic when we put in the temporary hip replacement. So now we move into surgery, and there are several stages. Stage 1 is a very difficult stage because most often there is a well-fixed implant. The implant is infected, and so it has to be removed, but it is bonded to bone. And so part of step 1 is removing the implant. And so we have special tools for the cup and we have special tools for the stem, but this does require a significant amount of time to remove a well-fixed implant. Then at the same time, we have to clean, or what we call debride, the soft tissues around the hip that appear to be infected. And then we wash out the hip with several liters of saline and antibiotic fluid. And then we put in an antibiotic-loaded temporary hip replacement to continue to deliver antibiotics locally to maintain some type of structural support and maintain a soft tissue envelope. There are 3 types of options we have, and I'll show you what we typically use. So once we've taken out the original infected hip replacement, we are left with this, what we call resection arthroplasty, or it's called a girdle stone, where here's a socket, here's the femur, and there's nothing connected. And this has actually been the historic treatment for hip arthritis, a girdle stone. And so a person can walk, but they just don't have a hip joint. This is one option to just leave nothing in the joint to reduce the risk of infection during the interval between stage 1 and stage 2. A more recent option is to use something called a hemispacer, where a cement spacer is used to reconstruct a ball and a stem. And this cement in this implant is loaded with antibiotics. More recently, we use what's called an articulated spacer or a complete spacer, where we have a stem, a cemented stem full of antibiotic cement on the femoral side, and we actually put in a cemented cup full of antibiotic on the acetabular side. This works, but sometimes a patient can be uncomfortable because here we have cement rubbing against bone. This now is protected with a polyethylene layer, and so we typically use an articulated spacer. Now, spacers are not ideal. They're not the same as a permanent total hip replacement, but they are an attempt to make the best of a difficult situation. So they're trying to maintain the space so the hip doesn't collapse with a girdle stone or a resection arthroplasty. And they're trying to maintain mobility so that a patient can do activities of daily living and meet their responsibilities. Most patients after spacer are able to be weight bearing as tolerated. Some people can use a cane or a walker, and some people can do limited walking without support. Most patients can do activities of daily living and return to desk work, and many people can return to driving. Again, it's not ideal, but it is a functional alternative compared to a resection arthroplasty. The interval between stage 1 and 2 is mostly run by the infectious disease team or the infectious disease consultant. And so cultures will have been sent either from the hip aspiration or from the time of the resection arthroplasty. The bacteria from the culture is grown, and hopefully a bacteria can be identified. Most importantly, so we know what kind of bacteria we are dealing with, and so we also know what that bacteria is susceptible to, specifically which antibiotic is most effective on that bacteria. From there, a patient will get a long-term IV. It's called a PICC line. The bacteria will be speciated, so we know, again, the type of organism, but most importantly, what it is, which antibiotics are sensitive to, and then nursing will be arranged so that antibiotics can be delivered at home for the next 4, 6, or 8 weeks. And again, I remind you, these are just broad generalization. Every patient is unique. This is not really medical advice. You should talk about it with your physician. This is just so that you have a general understanding of the process of a 2-stage exchange. A patient will typically get antibiotics, and we usually defer to the infectious disease team as to the duration, whether it's 4 weeks, 6 weeks, or 8 weeks. We then follow the laboratory markers, specifically the sed rate and the CRP, and we expect to see a gradual reduction over time. Once the CRP and the sed rate have returned to normal, we can be fairly confident that the infection has been eradicated. We then turn off the antibiotics to make sure that there has been a real eradication of bacteria and not just a suppression on antibiotics. And then we also check clinically to make sure the patient is feeling better, there's no temperature, and the wound is stable. The duration between stage 1 of removal and stage 2 reimplantation ranges anywhere between 2 to 4 months, but it can be much longer if the patient is comfortable. Once we have completed a course of antibiotics and determined that the labs have returned to normal and can believe with a high degree of probability that the infection is treated, we then proceed with stage 2 reimplantation. So we open up the hip again, we remove the antibiotic-loaded spacer, and this can typically be done far more easily than removing the permanent implant. We obtain tissue cultures, and then we also proceed with tissue analysis, and I'll tell you what that means shortly. And then we reimplant the permanent hip based on the amount of bone that's available. The way we determine that a hip has been treated for infection or is now cleaned of all infection is by looking at frozen sections of hip tissue. And so we'll obtain different samples from the hip, and the pathologist here will freeze them, and then we look for what's called polymorphonuclear cells. These are these little cloverleaf cells, and then we look for the amount of these cells. Here's one. Here's another one. Here's another one under a high power field. When there's no infection, we don't expect to see any. We expect to see fewer than 5. If the hip is infected, we see something like this where there are more than 5 to 10 or 20. And then this is a good indication that a hip is infected. And so we look at the slides with the pathologist during the surgery. And if the hip is clean, then we can proceed with the reimplantation. This is what the reimplantation looks like. So here we are after stage 1. We put in an antibiotic temporary spacer. You can see a hip replacement. It's got a cemented surrounding. This is all full of antibiotics that are specific to that bacteria. There's a polyethylene component and cement around that. We've gone back and then we've put in a permanent implant. We typically use a fluted taper modular stem with a dual mobility bearing system. The type of replacement we use will be a function of the amount of bone that's remaining. This patient, you can see, has a spacer here, but there's still a substantial amount of normal bone. And in this, we'll often use a proximal fitting stem or proximal filling stem with distal fixation. So it's a slightly different type of design because this patient has much more of her native anatomy remaining. This is an 11-year follow-up. So we can see with a 2-stage exchange, the studies show that there can be a 90% probability of success in treating infection over the long term. Final example, here we have an infected hip replacement. These are, again, well fixed, and so there's a lot of work in taking out well fixed implants. The hip has to be debrided and washed out. The patient will go on a course of antibiotics once the spacer is in place. Once it's clear that the laboratory values have normalized and the antibiotic course has been completed, the patient can be a candidate for reimplantation. And the actual stem that we choose will be based on the amount of bone deficiency and the amount of bone remaining. There's a lot of deficiency in this patient approximately, and so we'll use a distal bypass stem to compensate for that, and we can use a straightforward press-fit cup. Surgically, we know that patients after 2-stage exchange, right after surgery, are not out of the woods. There's often a lot of soft tissue deterioration from the infection, a lot of weakness from the limitations of therapy after surgery. We still restrict because there can also be bone and soft tissue loss, so patients are often partial weight bearing until there is clarity of bone ingrowth. Patients will often proceed with posterior precautions because these are often done from the back, and then we often place patients on extended oral antibiotics with the consultation of our infectious disease colleagues. All right, so that's a very high-level overview. It's most importantly, you have a very specific discussion of your situation with your physician. Every patient is a little bit different, and so there can be many nuances or variations from the typical 2-stage exchange protocol. It is a big deal to have an infection. Fortunately, 2-stage exchange is almost 90% effective in eradicating infection. Thank you.